Yeah, we are live now, ma'am. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, a dynamic dialogue on fertility, series 29, and the topic is clinical audit of IVF centers in association with Fertility Obstetrics Gynecology Continuing Education Society, Chennai, and A4 Hospitals and Fertility Center, Chennai. So it's my privilege to introduce the moderator of this webinar, Dr. Aruna Ashok ma'am. Ma'am is the clinical director and senior fertility consultant at A4 Hospital and Fertility Center, and also executive committee member of TAPISAR, advisory board member of FAME. Ma'am has received many gold medals in PG and UG. And also it's my privilege to introduce Dr. Sharmila ma'am. Ma'am is the consultant obstetrician and gynecologist at fertility specialist at A4 Fertility Center. Ma'am is the life member of Oxy. Presented posters in ESHRE 2023. Ma'am has published many papers and articles. I welcome you, ma'am, and I hand over the session to Aruna, ma'am.
Thank you, Sahiti, for introducing. We have today academic and research coordinator of in charge of Indra IVF with us, Dr. Nihar, who is very much into academics and he is passionate about teaching too. We are very happy to have you here. I'll hand over the session to Dr. Sharmila, who is going to moderate the session. Yes, Dr. Sharmila, you can take over.
Thank you, ma'am. Okay. So today's FOG webinar series will be on clinical audit in IVF centers. So we as a clinician will be trained after a reproductive medicine fellowship or any course, we'll be trained in doing the things like we'll be trained in IUI, we'll be trained in IVF. But when it comes to negative results, then we'll be like totally collapsed and all those things. So nothing to be collapsed when we know everything about auditing. So we should know about auditing of the lab and also clinical audit. So I think sir will today enlighten us about the clinical auditing of a IVF center so that if anything bad or negative results happens, we could be able to overcome it and correct it in the next cycle. So sir, Dr. Nihar Ranjan Boy, he's the head of Department of Clinical Research and Training, Indra IVF Center, India, and he is an ex-assistant professor in the Department of Obstetric and Gynecology, and he's an executive member of ISAR, Odisha chapter, and he's a member of HTRE, ASRM, BFS, EFS, ISAR, and IFS. And sir is having over 13 years of experience in ART and laparoscopy, and his area of interest is luteal phase manipulation, regenerative medicine, and fertility enhancing laparoscopy. Over to you, sir.
Thank you, Sharmila, for this nice introduction. Thanks again. So let me share my screen and we'll start. Should we, I think adequate number of attendants are there. Are we still waiting or we'll go ahead?
We can go ahead. People will be joining in 5-10 minutes, but we'll go ahead to maintain the time.
Okay. I think it's visible.
Yes, seems.
Okay. So while we are doing some practices, it's never like that. I never make mistakes. Just like ostrich dips its head inside the hollow when any anticipated storm comes. So you cannot close your eyes and think that I never make mistakes. So always you have to keep your eyes open and you should be prepared for any anticipated mishaps, and you should keep yourself prepared how to overcome that. So I'll be covering overview of KPI, the importance of accreditation, importance of audit, types of audit, process of clinical audit, and I'll give some example how we perform it. Then the challenges in audit, and finally conclude. So while we are talking about KPIs, KPI stands for key performance indicators. These are the ultimate thing that you are going to achieve. So any clinic, any hospital, they are working for some KPIs to achieve some competency or benchmark. So there is a basic difference between competency and benchmark. Once you are achieving the minimum standard, that is the competency. Once, let's say, cycle cancellation rate. Cycle cancellation rate is different for poor responders and different for normal or hyper responders. So cycle cancellation rate may go up to 3% only in case of normal or hyper responders, but you can think of 30% cycle cancellation as the competency, as the minimum possible in poor responders. And while you are talking about the benchmarks, benchmark is the highest standard you can achieve, or you can set your goal, you can set your target. So there are many, but I highlighted few only. Many KPIs as per Mariber consensus, as per Vienna consensus. There are many KPIs that embryology lab or embryology or IVF clinic they work for. But these are few clinical KPIs. Let's say cycle cancellation rate, FOI, maybe M2 rate or retrieval rate, complication rate, ICSI fertilization rate, or proportion of embryos formation rate, total blast formation rate. All these are KPIs. So I am not going to highlight all these KPIs. My intention is to make you orient why we are, how we can measure our performance. So there should be something that should be measurable. All these things, these are measurable. Means when you are measuring something, it will be coming as a rate or ratio like that. So if you can see all these are rates. Complication rate, fertilization rate, pregnancy rate, multiple gestation rate, miscarriage rate. So all these are measurable. And for any research you do, whenever you talk about the outcomes, another thing you should remember, that is always measurable. Whenever you will be talking about outcomes, outcome measures, the endpoints, those are always measurable. So similarly, all key performance indicators are the measurable parameters that guides whether your clinic is performing good, whether it is at the anticipated baseline, or it is performing midways, or it is achieving the benchmark that is as per the standards. Again, I want to highlight something. If you are talking about benchmark, whatever this is written here, that may not be fitting to your clinic. That may be international standard, that may be national standard, but you have to fix your benchmarks, and the competency always you follow some standards, and these benchmarks you may or may not be achievable, but competency you have to achieve. Okay. So how to achieve better KPIs? All these KPIs means quality care and best performing lab, patient satisfaction, all together in combination can achieve a better KPI. There is no question about that. So there comes the role of accreditation. So what is the role of accreditation here? Accreditation is something, a third-party agency, they audit your lab, they audit your clinic, and they give the certification, may it be ISO certification, may it be QIS certification, accreditation, may it be RTAC accreditation. That is different for different nations. Different nations, they make it mandatory, and few nations they make it optional. it is better to go for accreditation, but it is not mandatory in few countries. Maybe Australia. Australia, it is mandatory. You have to go for RTAC standards. If RTAC accreditation is not there in your clinic, you will not be able to perform any procedure like that. But if in India, it is not mandatory, but you can go for accreditation. That may be QA accreditation, may it be ISO accreditation, may it be RTAC accreditation, anything. Why it is essential in IVF clinic? It is essential in IVF clinic to ensure high quality patient care, improve outcomes, and maintain the standards. Okay, so these are some examples of accreditations. In Australia, it is RTAC. In Canada, it is Canadian Council of Health Services Accreditation, or CCHSA. In UK, it is CPA, Clinical Pathology Accreditation. USA, it is Joint Commission of Accreditation Healthcare Organization. In India, maybe people are following QI, and ISO also being followed. So coming, going deep into that, little more, QI, Quality Accreditation Institute. There are many points. May it be governance and leadership, may it be human resource management, facility and risk management, information management system, continual quality improvement. There are many points. If you count the points, number of standards, 91 major headings are there where they check for the complaints. And if you count individual points, it goes up to 421. It is the previous one. Now they have updated it more. Maybe these points are going beyond 1,000 like that. Number of criteria. So clinical audit. Clinical audit is a small, very small part of patient assessment and care that comes under clinical audit. So if we are talking about 1,000 points, maybe clinical audit overall topic, if you consider one single topic, it hardly comes with some points. So it is a small part, but important point. So audit is the only way to assure policy implementation. Whatever policy you are making, whether it is being implemented properly, that you can only know from audit. If you are not doing any audit, you will be closing your eyes, sitting on your chamber, and think that everything is going smooth unless any mishap happens. You will miss those near miss cases. So clinical audits in an IVF clinic is essential to maintain or to ensure high standard of patient care, improving success and maintaining complaints. By definition, it is a systematic process used to assess, evaluate, and improve patient care through a systematic review of care against set criteria and implementation of change. So here I want to highlight two things in this definition. It is to assess, evaluate, and improve the care by reviewing through the set criteria. Set criteria, I just want to emphasize the word set criteria. And the second thing I want to highlight, that is the implementation of change. If you are finding any loophole, if you are finding any mismatch or mistake as per your set criteria, then you have to go for the changes. You have to implement the changes. Unless you are implementing the changes, there is no way, no purpose of doing the audit. So all these things has been discussed till now, but just to summarize, so the benefits of clinical audit: improve patient outcome. That by a clinical audit helps identify the area of improvement, leading to a better treatment outcome, increased patient satisfaction. Simple. Then enhanced quality care. Audit ensures that care is evidence-based. So evidence-based means, when you are talking about evidence-based, that evidence may be international standard that is already published, or the people always think that evidence-based means it is already published. But one more thing that is more relevant to your clinic, that is your own findings, your own result, own analysis, your own clinic analysis, because you are catering to a different group of populations and you are referring to a study that is done in a different population. Might be European population, you are referring a study that is highlighting a multipetal gestation of maybe 10% or less, but in your practice your multipetal gestation rate is going up to 35%. So you cannot compare that 10% with 35%. Okay. So it ensures that protocols are followed, resulting in a high quality care. So you have to set your, you have to create your own evidence. You have to set your own protocol. So setting the protocol is again a very important thing. Then the reduced risk clinical audit identifies the potential risks and near misses, enabling proactive measures to prevent adverse event. So it should not happen that any mishap happened, then you are thinking of that. It is better you should prevent that. No mishap should happen. Then accreditation and compliance, how it is impacted. Clinical audit demonstrates a commitment to quality and safety, so facilitating accreditation and compliance with regulatory requirements. So regulatory requirement also taken care of. Let it be audit, let it be the registration part, let it be the staff, let it be documentation. All these things are covered in this. So types of clinical audit, it can be a simple way, peer review, or it can be retrospective audit, it can be prospective audit. So what happens in peer review? So it is review of patient care by colleague to ensure adherence to standard and protocols. Let's say you are doing some procedures, simple, let's say ultrasound, you are doing scans, and make it sure maybe 10% of your scans are being audited by your own colleague. If they're available physically there, then and there, you ask them, you just review my findings. Is it okay? Am I missing something? So that is simple peer review. If no colleague is available at your center, you can ask somebody online who can be there and review your reports. That is simple peer review. And if you want it to be more better, then it can be retrospective audit. Retrospective audit means you have done some cases, you have treated the patient. Now you have all data with you. You collect with some format, then you try to review that whether any mistake I did. On prospective audit, whenever you are continuing the process, you just collect the data and analyze simultaneously or after a time frame, certain time frame. This is now I am coming to the real topic, that is the clinical audit process, how we perform, how it has to be done, how we have set the criteria. So selection of clinical audit topic is the most important thing. If you are finding any dip in result in some areas, you can think of why it is happening. Let's audit it. So it can be anything. It can be anything. Let's say your cycle cancellation is going up. So why the cycle cancellation is going up? You can think of stimulation. For at which point your cycle cancellation is going up? Maybe before OPU, maybe before embryo transfer. So you think of where it can go wrong. If you want to audit your cycle cancellation, then you set the topic, then you form a team. Constitute the clinical team. Clinical team should be a mix of population, one clinician, one pharmacist, one lab person, one MRD person. So that should be a mixture of team, mixture of members that should form a team. It should not be uniform one. Only clinicians, they cannot make a team. Only embryologists, they cannot make a team. It will be a biased opinion. Then you have to define what parameters you want to audit. Then you develop the tool, development of audit tool. I'll show some examples so that you will be able to understand what is a audit tool. Audit tool is not predefined. It can be predefined. You can get it from some institute, they have made that, some university, they have made that, some audit tools, already validated one, or else you can develop it as your own. For us, we have developed the audit tool from our own institute. Then you have to collect the data and analyze. Then from this analysis, you have to prepare a report or the findings as per the statistical results. And the last and most important is how you are doing the process improvement. What steps you are going to take. So corrective measures, that is most important. If you are finding anything wrong, what corrective measures you are planning. Once you set the corrective measures, then you plan a time frame where you can do the re-audit. So there are many tools available to perform the audit. You can go for a spreadsheet. That is the simplest way you can go for. That is the Excel spreadsheet, where you can collect the data and analyze take the help of any statistician. They will do the analysis for you. Or there are specialized software also. So clinic management system, including clinical audit tools, or IVF clinic management software, that some softwares they provide the audit tools. Some web-based software, maybe the community-based, they don't charge even, but you have to make the data open to them, raw data. They have the access to the raw data. So that is your call. So now this is another important thing. What is your reference literature? What reference literature you are going to follow? You can follow the guidelines or protocols. It can be from any society, ASRM, SRA, national guidelines, international guidelines, any guidelines you can follow. And here again, I must emphasize on institutional SOPs, because all of our protocols, all of our SOP, standard operating procedures, that has been developed from all these guidelines, with reference to all these guidelines, and from our own experience, from the results, from internal analysis. So institutional SOP is the main reference tool for us to conduct any audit. So data collection, it can be from the treatment outcome, complications, patient satisfaction score, maybe any survey or tools like that. Then laboratory results, that can be anything that can be coming as a hard copy or as a soft copy, that can be integrated to your system, EMR system. So for us, we have incorporated the EMR system into our lab test. So the report come directly to our EMR system. So here again, that I have already highlighted before also. Benchmarking or competency. So you can follow these Society for Assisted Reproductive Technology benchmarking, Joint Commission accreditation benchmarking, or any local or international bodies or national bodies. You can follow their benchmarking. But what we do practically, We first analyze our own data. We find out what is the mean for that particular thing. Let's say cycle cancellation. Let's say for this particular age group, we are finding cycle cancellation as 10%. So we calculate one below and one standard deviation above. So the standard deviation below, we keep it as competency for all centers. We make that, we ensure that everybody has to manage the competency level. And if you are achieving one standard deviation above the national average, then that is the benchmark set for you. Once we achieve all these competency, automatically our mean or average goes up. So maybe in the next year, we reset our benchmarking and reset our competency. So this is a self-improvement that we set for ourselves. Obviously, we try to compare it with international standard. Sometimes we are performing better than the international benchmarks also, and sometimes we're lagging behind. But it's majority time we are above the benchmark set by the international societies. So now comes the challenges and limitations of clinical audit in IVF clinic. So data related, it can be data related, it can be resource related challenges. Data related challenges may be data quality and accuracy, how and who and how the data is being collected, whether it is directly incorporated in the EMR system, whether the data scrutiny is being done, data audit is being done regularly or not. So that makes sense. Whether you are getting a clean data. If you are not getting a clean data, then and there you have to track it down so that getting the clean data makes it more robust. What is happening in our system, that is the EMR, electronic medical record system, that where all our data is being put there, and anytime we can download that. So that is a good way. It is paperless. Almost we are almost paperless. So that is a good practice, but I don't know if all clinics, all individual clinics, that is achievable. That requires some manpower, obviously. So resource related challenges, maybe that comes the next. So time and personal constraint. Let's say you have some constraints in manpower, then obviously they will be hesitant to do all these data entries, all paperless works, all those things. And it takes time, simple. And once you increase the person, it increases the burden, financial burden, and the limited IT infrastructure. That may be another challenge. So again, it can be staff related challenges, the just in continuation. So staff engagement means you have to engage your staff for this work, for audit work. So they might not aligned with you. They might not support you. They might think it is extra burden. Then sorry, every staff is not that prone, that competent to learn things quickly. So you can arrange multiple training sessions or education sessions. That again consumes time and manpower. So once you do this regularly, you are increasing the burden on staff. Maybe the retention issue will be there. They might leave you and they can search for another job. So you have to overcome these challenges. Then methodological challenges. Defining the audit criteria, clear and relevant audit criteria is the most important thing. That is the heart of your audit. So if you are not clear about your objective and aims, what you are going to achieve with the audit, then it is just a waste of time and money. So you have to be more focused, more clear why you are doing this audit, what is your objective. Then on which population, you should not intermix the population. Maybe you are doing one audit on poor responders and you are not getting adequate sample. Now you are trying to get some files with normal responders. So it doesn't make sense. It will not come up with any meaningful results. So your audit results, should be meaningful and actionable. So unless you choose the relevant criteria, relevant topic, and the relevant tool you are using, you will not be able to find out a meaningful result. So it is really, really important. Then implementation and sustainability challenges. Once you do one audit, that doesn't mean you are done. It has to be repeated. The momentum has to continue. It has to sustain. So you have to fix the frequency. Okay, after this many months, after this many days, I am going to do the re-audit, or I am going to audit in a different topic. So that momentum has to set, that culture has to set in the system. And then the external challenges like regulatory and accreditation requirements. So sometimes there are some topics you are auditing and that is not aligned with the regulatory affairs. So you might be stuck there, and that may impact patient experience. When you are dealing with patient, when you are going with a prospective audit, so you will be questioning, you will be surveying the patient, whether this one, you will be asking many questions. So in that time, patient might not like that. And public perception, this patient may be putting some wrong words in a, no, they are just questioning, bothering us. So perception might change to your clinic. So you have to keep that in mind. So just to highlight, we go for monthly, quarterly, half yearly, and yearly audits. It's up to you. You can set your own targets. Then audit fund that include we audit the people, the personnel, whether their skill level is good or not. Process means they are following the set SOP process or not. Whether equipment is maintained or not. Whether they are what of present training status of the personnels, how frequently they are attending the trainings, and whether they are implementing that or not, any new changes. And audit can be planned, or it can be KPI specific audit, it can be surprise audit, or it can be done physically or online. Okay. So remote monitoring also can be done through our many online tools. Electronic witness system, HIS, all data is accessible centrally. So anytime we can do that as a evidence. So just to summarize all these things, I am citing one example here, how clinical audit we do. Multipetal gestation rate was a concern for us. Maybe more than 25% multipetal gestation was there in our system, that was a concern. So, but international competency is less than 10% and benchmark is set at 5, because if you go to any European country, they go for SCT as of now. In today's era, they are almost shifted to SCT than DET. So their winning rate is too low. It is hard to achieve these things if you think in 3-year, 5-year timeline also, because our practice is for DET and our results for DET is more as compared to SCT. So obviously patient are denying, or consultants are not convinced much to go for ACT. So how to achieve? So can it be achievable with a 30%, maybe 30% winning rate coming down to 10%? What is the loophole? That was the question. Okay, how to achieve that? So the question is, the hypothesis is, if we can bring down the double embryo transfer rate, or if we can promote the single embryo transfer rate, that will directly impact these rates. So as per our we made some SOP for that, and we started with a team, clinical audit team, maybe clinical head, senior consultant, MRD executive, nursing head, and clinical coordinator, the made a team. So this is the standard thing. We mix up teams, and once the team is formed, then what parameters we need to check: the eligibility for ACT, whether that was there, whether contraindication for DT was there, and still then they went for DT, whether patient education was perfect, whether patient consented for ACT or consented for DT, in contrast to the advice. So all patients who underwent embryo transfer, you can go for retrospective or you can go for prospective. That is quite okay. So this is the tool that I was talking about. Means these are the checklist. Whether patient is eligible for ACT, you pick some criteria, maybe institutional criteria, or you can follow any international standard or maybe national standard or any guidelines. Sorry. And we have made one checklist for any absolute contraindication for DT. If there was any absolute contraindication for DT, they have to go for ACT. If they have gone for DT, then it is a non-compliance. Maybe it is not fully visible. Is it visible to all? Means, is it readable? The full page is not displayed here. So patient with a favorable prognosis who can be considered for ACT is the second option. We set some criteria where ACT can be considered in this group of patients. And the last part of this is the patient education and informed consent. After knowing all pros and cons, patient has to choose finally whether they want to go for ACT or DT. So let's say all these criterias are going sorry, going towards ACT. ACT is the recommendation in particular some case, and with some prior knowledge or something, patient wants to go for DT. Then this can be a partial compliance, but it cannot be a non-compliance. So if you can remember the previous page, let's say the serial number A 1 2 3 4 15, B 1 2 3 like that, C D that is hidden because it was not compatible with the font size. It is not visible here. I'll show that Excel if you want. So individually, you can collect one patient. The unique hospital identity number you can write here. Patient initials. No need to disclose the names. Maybe Sunita Kumar, you can write SK. Husband maybe Prabhat Kumar, like that. PK you can write like that. So where uh, absolute contraindication for DT was there or not? If any of the criteria was there, so it should be written as um, uh, absolute contraindication, yes. So this would go for ACT like that. So eligibility criteria for ACT, if every points in the second um, point means B, favorable prognosis for ACT was there, so it can be written as yes or no accordingly. And how we go for compliance check like this. So if ACT was indicated and ACT was done, then it is compliant. If ACT was indicated but DET was done as patient consented for DET, then it can be partial compliant. If ACT was indicated but clinician planned for DET, then it is a non-compliance. So why there is non-compliance? You have to catch hold of those files. Once you get all those files, the non-compliance rate is 10%. You catch hold of those files and go and ask the consultant why it is. If the institute has set these criteria, why you are debating that? So there should be sufficient justification. If not, then you can issue one warning like that. This is for twin. I am just giving one example, but similarly, you can plan for like complication rate, maybe for cancellation rate, maybe the if you are not finding good clinical pregnancy rate, maybe the rate is going down, then you can think of how to improve that. So there are many things. Then compliance for patient education or consent, then that comes on the uh, point D. So the criteria is already set, whether it is a partial compliance or non-compliance or a complete compliance. So accordingly, you can find out where is the fault and you can plan how to set the corrective action. Okay. So clinical audit is a vital component of quality improvement in IVF clinic, enhancing patient care and outcomes. By understanding the benefits, types, and process of clinical audit, fertility consultants can play a key role in driving quality improvement. And ongoing commitment to clinical audit ensures that IVF clinic provides high quality patient-centered care. And it is all is well till disaster strikes. If you remember Captain Smith from Titanic, it was unsinkable. It was once thought unsinkable, but Murphy's law says if anything can go wrong, it will go wrong. So you have to plan it, you have to audit it, you have to find the loopholes, and you have to take the corrective measures. Thank you. Thank you for patient listening, and I am available for questions. Hello.
Hello, good evening, sir. I just had one question to ask.
Yeah, please.
So, when we are defining various parameters for auditing in
Yeah.
various sections of the IVF lab, so won't it be very cumbersome to take lots of parameters? So, how do we identify which are the most important parameters and how we
So truly speaking, it's not a single point or few points. Those are important. It's all points that is important. It's a chain of event. If you are missing any particular point, means that leads to the next step. So that can be some mistake can happen in the next step. So it's not that one point is important, it's all point important. But for all clinical or all practical purposes, you can set the critical points as per your experience. It is not arbitrarily fixed as per your expertise. You can take help of the seniors. Getting.
Any other questions? Embryologists and clinicians all are there. Dr. Sharmila?
I purposefully didn't cover the embryology audit.
Yeah.
Embryology audit is again, that is a long thing. So maybe if you count the points that is being covered in our embryology audit, that goes up to maybe 500 or 600 like that.
So the clinical audits, whenever the benchmarks it's above or below the benchmark, you wanted to do a clinical audit. Clinical audit is done for the parameters that you check, or prospectively also without a problem. Also, you regularly do a clinical audit.
Let's say just I showed the example, the twinning rate, yeah, multipetal gestation rate.
Yeah.
So that is the present scenario that is too critical for us some operational reason. So we are doing that in prospective way. We just don't want to lose one patient like that. So when it is too critical, we go it for prospective audit. But retrospective, anytime, any topic we can take as retrospective one.
Okay.
Sir, excuse me, sir.
Yeah, please.
Is there any interval duration for audits for a small clinics and like if you're a level 1 ART center and level 2 with the minimal patient inflow, is there any duration within 3 months or depending on the how effective will be the audit?
If it is a very low draining, means the patient load is less only, you can think of going for a quarterly or half yearly audit. That should be okay. There is no set criteria as such. Okay, what should be the frequency? But
Okay,
you
sir.
can conveniently you can think of where you should be getting at least a handful of sample size. Sample size exactly we calculate. We take the help of the statistician and we calculate the sample size. What should be the power and what you are anticipating? What should be the compliance rate? If you are anticipating a compliance rate of 80% and if you are anticipating a compliance rate of 90%, then obviously the sample size will vary. If you are happy with low compliance rate, then the sample size will be low only.
Okay, so auditing first we have to collect the data. We should get a help from a statistician also, like it is better.
Couldn't get you.
To get an audit, that
Yeah.
statistics, we have to have an contact with the statistician too.
Yeah.
Mm.
Anyhow, you can yourself also calculate the compliance rate. It's nothing a great job, but it's always better to have one statistician. With Excel, you can calculate the percentage. That's the only thing. Let's say out of 100, 85 is satisfying the complaints, then your compliance rate becomes 85%, right? Your partial compliance, let's say 10 people, it is partial complaints and 5 is non-compliance. So non-compliance rate becomes 5% like that. So it's calculating the percentage only. Nothing big in that.
Okay, sir.
Regarding the parameters that you use for clinical audit, for example, starting the IVF cycle, if the stimulation is being done, what are the parameters you check for stimulation? What are the key performance indicator to tell that the stimulation that we did is good? that you check usually in your clinics?
Yeah, if we are talking about the stimulation, whether it is good or not, whether we set the criteria like uh, the total dose consumption,
Okay.
then the FORT,
Okay.
the FOI, the
Yeah.
retrieval rate,
Yes.
and M2 rate.
Okay.
And maybe going further, you can check for the blast rate and good blast rate.
Okay. Uh, the subjective, it becomes subjective. So, just a minute. It as many a times this though FOI and FORT we are calculating and we document it. It is a subjective analysis, I feel, because though we have a 3D ultrasound and we measure sono AVC and everything, there is little bit of subjective issue in FOI and FORT. How
Yeah,
do
yeah.
you overcome it?
That will be always there. That will be always there. That much discrepancy will be there. So what we are writing one manuscript on that only on FY, FORT, how it is impacted, whether by uh, ovarian reserve or age. That is
Okay.
going to be submitted soon. So there also we found lot many deviations from FOI, FORT
Yes.
because the AFC count is not totally reliable. Means it's not 100% reliable.
Yeah.
So the higher count we excluded
Okay. That
because
makes sense actually. Yeah.
yeah, because once AFC goes beyond 20, 25, nobody that keenly observes that and counts properly. They just write it 25, 28, 45 like that.
Yes.
We excluded those outliers. Then
Oh,
we could find as uniform data.
yeah. Because of these PCOS patients are deviating the whole data.
Yeah.
Even the blast rate, we felt that if we take PCOS, it becomes little bit variant. When we
That
take a
would,
responders and a low responder, it is coherent. And
yeah,
oocyte recovery rate, do you take it? ORR? Oocyte recovery rate?
retrieval rate you are talking about.
Yeah, oocyte retrieval it is called as recovery rate, but most of the studies do only FOI and FORT. But a number of follicles puncture to know the efficiency of the surgeon who's doing the pickup. Do you follow that? No.
Yeah, that only means the retrieval rate only that we calculate
Okay.
means the expected number of follicles and the retrieved number of follicles,
Retrieved number of
retrieved
follicles.
number of oocytes. So that is not surgeon's efficiency only. Sometimes maybe the bigger follicles they give
They
rise
don't
to.
have oocytes also. Yeah.
Yeah.
Coming to the embryo transfer, do you just check the grade of the blast and then the positive rate? Do you have any other parameters to check how the HRT preparation is, how the transfer has been done? If the results are pregnancy rates are lesser, how do you audit from the pickup to the embryo transfer from the lab? How do you know where is the problem? How do you score it or how you assess it?
So we segregate into two parts up to blast maybe we segregate as one part and beyond that we think of as another part like that. So once a good blast is formed,
Okay.
so we just disregard, not forget, we just disregard if there was any fault in the stimulation part, because
Okay.
stimulation was good, then only we are reaching the stage of blast.
Okay.
So after that, what was the grade of embryo that has been frozen, whether there was any male factor that also we take into account, but the major part depends on the HRT protocol and the endometrial factor there. And sometimes we go for the testing, aneuploidy testing also.
Okay.
Uh, that we consider as one of the factors, maybe that is leading to uh, non-implantation or failed implantation.
I saw in your CV that you're interested in luteal support investigation or analysis. It was a very different one. No, I have not seen a person who is very much interested in luteal support. So, how do you audit whether the luteal support is good or not? Or how do you see what is the variety of luteal support you think of? If the patient is becoming negative, you would look at the luteal support, what was given also.
Yeah, luteal that I mentioned, that is luteal phase manipulation.
Manipulation.
And
Okay.
yeah, and luteal support also, that is one of my area of interest. So luteal support depends on different category of patients, maybe normal uterus, maybe adenomatic, endometriotic, maybe postmenopausal. So I am very fond of, now I am shifting my practice. I am more oriented towards a modified natural cycle.
Okay.
Yeah. So now another protocol also we are trying. That is um, that is another modification to the natural cycle where we are not giving any trigger.
Just when the follicle is good and the endometrium is good, you start the progesterone.
Yeah.
Yes, there was lots of talk about it.
Yeah,
But
yeah, yeah.
how do you feel the cancellation rate in modified natural cycle? Many patients follicle rupture before you. Do you find higher cancellation rate in HRT when you start a natural cycle?
Yeah, cancellation rate is little more, but what is our protocol for that? Instead of waiting for 18, 19 mm, 15, 16 is adequate size where you can trigger.
Okay.
Yeah. So if you're practicing at 15, 16 to trigger, then the cancellation chances will go down.
Okay.
Yeah, that goes down drastically.
Okay.
And that is adequate, enough adequate.
If you follow a modified natural cycle, what is the luteal support you advise to the patient? Do you still give progesterone, oral and vaginal and everything, or you reduce it drastically? We're a little bit worried to reduce it drastically sometimes.
If you are following the modified natural cycle, maybe by 6 to 8 weeks, you can start reducing your usual progesterone. No need to go for full support, abundant progesterone after
Okay.
6 to 8 weeks. Uh,
Okay.
yeah, again, that is again another RCT we are following also in FET cycle. Even we are trying to stop the progesterone at 8 weeks, not continuing till 12.
Okay. So in modified natural, you can stop it. Do you still give oral and vaginal for these patients also, or reduce the dose of progesterone also?
Yeah, we go for reduced dose of progesterone, but though we go for both the routes.
Okay, fine.
Yeah.
So fine. It is a never-ending process. I think clinical audit. The other center has to develop their own clinical audit,
Yeah,
and
yeah. Very
you
good.
patiently, the very important and confusing thing, you patiently explained it very well. We are very happy to have you here. We find that not all the doctors who practice can teach. There are only certain people who practice and then teach also to others. Knowledge sharing is always very good. Thank you. I think
Thank
Dr.
you.
Sharmila is having issues with the network and she couldn't connect. Thank you on her behalf also. Thank you. Thanks a
Thank
lot.
you.
Thank you for sparing your time. Thank you.
Thank you. Welcome.
Yeah, thank you.
Okay. Thank
Yes.
you, everyone. Bye bye.
We will send you a mail of this participation also. Thanks a lot. Yeah,
Yeah, sure. Thank you.
thank you.